Good evening, sir. Can I begin, sir?
Yeah.
Yes. I'll be presenting a case of a 53-year-old male XYZ hailing from Nellore, who is an agriculturist by occupation, studied until BSc, was examined on 1st of April, who came with the chief complaints of palpitation since 1 year, breathlessness in 6 months, easy fatigability since 5 months, swelling of lower limbs since 3 months. Coming to the history of presenting illness, patient was apparently all right, performing his daily activities until 1 year ago, when he noticed palpitations which were insidious in onset. They were regular, occurred on a daily basis on exertion. They reduced on taking rest, and there is no associated prominent neck veins, post-palpitational diuresis or syncope, or associated chest pain, breathlessness, or fatigue when the symptoms started. 6 months later, the patient developed breathlessness without wheeze, which was insidious in onset and progressive in nature, such that initially it occurred on exertion of walking about 2 flights of stairs and 500 meters from the level ground, which progressed to the current state for which the patient was hospitalized, wherein he developed breathlessness on walking 50 meters inside the home, which is NYHA class 2 to class 4 progression. He also complained that he had awakening from sleep 2 hours after the onset of sleep, which was relieved on sitting on the bed and leaning forward and taking deep breaths. This occurred after 1.5 months after noticing the breathlessness, and which has disappeared since the past 3-4 months after the onset of development of this swelling of the lower limb. Since 2 months, he is also having associated orthopnea, for which initially he had taken some medications and was not regular with those medications. There is associated fatigue that the patient has noticed since the past 5 to 6 months. There is no history of cough, expectoration, wheeze, or fever that the patient has noticed. There is history of swelling of bilateral lower limb since 3 months, which is painless, progressive, and currently up to the mid-thigh. This is on admission. There is no redness or early morning facial puffiness, abdominal distension, jaundice, hematemesis, or melena that the patient has noticed. There is no history of frothy urine. There is no history of giddiness, loss of consciousness, suggestive of syncope or pre-syncope. No history of nocturnal palpitations or chest pain. No history of recurrent respiratory tract infections during childhood. No history of fever, hemoptysis, weakness of limbs, or blurring of vision. Coming to the treatment history, for the above mentioned complaints, patient was taken to a local hospital, for which he was evaluated and told to have a structural heart disease, especially a valve problem, and was recommended a valve replacement. And initially was started on medications which increased his urine volume and frequency, after which his symptoms of breathlessness came down. However, the symptoms recurred after stopping the medications. The patient was referred to our hospital in view of the following the above symptoms. Following admissions and treatment, his pedal edema and orthopnea subsided, and patient is currently in NYHA class 3 breathlessness. Patient has no known comorbidities. There is no history of recurrent respiratory tract infection in childhood or fever, migratory joint pain, especially involving the large joints, or history of taking injections every 21 days. There's no history of diabetes, hypertension, tuberculosis, thyroid disorder, or seizure disorder. Family history, patient is born out of a non-consanguineous marriage, second of 5 children, has 2 children, and there is no cardiac complaints in the family. Personal history consumes a mixed diet. The appetite has been reduced since 1 month. Bowel bladder habits have been regular, except during the time when he was started on the medications. Sleep has been disturbed, and he denies any deleterious habits. Coming to the summary of my case, we have a 53-year-old male patient with no comorbidities, presenting with progressive regular exertional palpitations, probably volume overload type since 1 year, with progressive dyspnea, progressing from NYHA class 2 to class 4 with associated orthopnea, fatigue and painless swelling of bilateral lower limbs, with partial relief on oral medications, with no chest pain, syncope, abdominal distension, or fever. In sinus rhythm with no signs of infective endocarditis, no symptoms of infective endocarditis or rheumatic activity. So I would like to think of possibilities. The differential I would like to consider are the valvular heart disease. Coming to the analysis of the history, based on the history analysis, we have palpitations. And because they are regular and exertional and occurring on a daily basis, I would like to think of the presence of a volume overload state. And because they are reducing on taking rest and worsening on exertion, probably it may be a mitral valve disease compared to an aortic valve disease, or it may be a combined mitral with an aortic valve disease with predominant mitral valve disease.
In the palpitations alone, can you tell me all those things, that mitral and aortic?
No, sir, we can't. Based on the all the history together, probably
No,
we have
only
to.
that's what. Okay, so in palpitations, when it is predominantly, if it is a mitral valve disease,
Yes,
which we are thinking of, what would be the palpitations like?
yes, sir. Palpitations usually it will be regular, and
In
initially
mitral valve, if it is mitral valve which is there,
isolated mitral valve involvement. It may have irregular palpitations due to development of atrial fibrillation.
maybe based on that you can say maybe it is a mitral valve. Otherwise, I think by palpitations may not be. You can't say isolated whether it's mitral or aortic. So here you have regular palpitation which is occurring during exertion.
Yes.
So you said this. What is the cause for these palpitations?
So probably it is because of a volume overload condition.
Okay, that could be one mechanism.
One possibility.
Yes.
The second possibility is he may have an underlying anemia that may itself worsen.
That can't be going on for such a long time.
Long time.
So one is change, that's a structural change in the heart, that is, you said a volume overload or something like that. Other mechanisms of palpitations?
Another possibilities can be arrhythmias, where it can be a sinus.
Okay, so change in the rhythm of the heart. Change in the rhythm of the heart. Okay. Or change in the
rate of the heart.
The rate of the heart. That could be the three mechanisms that could be there. So here it's saying regular. You said there is no prominent neck veins. What would that indicate?
It would indicate a paroxysmal supraventricular tachycardias, where the patient may feel prominent neck veins.
Okay.
Which has a sudden onset and sudden offset with
sudden onset, sudden offset, which has
post-palpitational diuresis may have.
Post-palpitation diuresis, possibly. That could suggest supraventricular. Okay. So what's the definition of palpitation?
It's awareness of uncomfortable awareness of one's own heartbeat.
Okay, it's an unpleasant awareness of one's own heartbeat that is there. Okay. So more often, okay, palpitations could be due to various causes, as you said. It could be just the chamber enlargement per se itself can cause, or it could be due to your rhythm disturbances. So based on this palpitation, I think we cannot. If it was irregular and maybe associated with pole palpitation diuresis, maybe we could have said it could be a supraventricular palpitation or arrhythmia that could be there, or an atrial fibrillation. But otherwise, all the mechanisms would still hold good just based on the palpitations.
Yes.
Yeah. The next symptom you said was?
Breathlessness, sir.
Okay.
So initially the patient had NYHA class 2, which gradually progressed to NYHA class 4. I'm thinking in terms of first thing we have to consider whether it is a cardiac or a respiratory cause of breathlessness. So because there is no cough, there is no wheeze, there is no fever, and no expectoration, I would like to consider the possibility of breathlessness being of cardiac origin.
Okay.
When you're taking cardiac origin, presence of breathlessness may indicate a left ventricular dysfunction, possible left ventricular dysfunction, left heart failure.
Okay.
And this patient, the other feature
one mechanism you said is left ventricular dysfunction, which produces a progressive exertional dyspnea, which is the other mechanism where progressive exertional dyspnea can occur.
So one can be because of the patient may also have pulmonary hypertension that can cause breathlessness.
So pulmonary hypertension. So there is a pulmonary hypertension, or there could be a left ventricular dysfunction. So based on your history, can you differentiate the two?
So if there is pulmonary hypertension, the patient may initially present with more of a right heart failure symptoms rather than initial.
Heart failure would occur. Heart failure would occur eventually whenever it is.
Yes, sir. The other thing going in favor of a LV dysfunction is the presence of orthopnea and PND.
Okay. Anything else? Just based on the progressive exertional dyspnea, can you differentiate whether it is pulmonary hypertension or it is LV dysfunction?
Not sure how, sir.
You say a patient has a pulmonary hypertension. What are the common diseases that you have under that?
We may have obstructive, like secondary to a respiratory disease, like
could be respiratory, cardiac,
idiopathic connective tissue disorders or primary pulmonary hypertension.
Common one, cardiac, valvular.
Mitral valve disease, mitral stenosis.
Mitral valve disease, isn't it? Mitral valve disease producing pulmonary hypertension, that can be there. So what's the basic difference between an LV dysfunction versus a pulmonary hypertension? Here you said there is a progressive worsening within the past 6 months, isn't it? It has worsened so much, so fast.
Usually, it will be rapid progression with an LV disease, left ventricular disease compared to RV dysfunction.
Okay, so if it's a left ventricular dysfunction, unless something is done, there is a pretty rapid progression in the grading. It becomes faster progress. Whereas what is the classical history in an emphysema patient? How long will they have this exertional dyspnea?
It may go on for years and until they decompensate.
So long years, so more than 5 years, more than 8 years. You have a long history of progressive exertional dyspnea from stage 1 to stage 2, then going on like that for a real long time. So longer history, especially the arbitrary cutoff of 5 years. So if it is longer than that, there is more suggestive of pulmonary hypertension being the etiology for your progressive exertional dyspnea, and it's less than 2 years as it's occurring in your patient. Pretty rapid there. So it's more suggestive of LV dysfunction. You already told that the LV dysfunction, the other features that you're having here is orthopnea and PND, which will not be there in a patient with, it will not be there in pulmonary hypertension as a mechanism. That is one of the differentiating feature that could be there. Dr. Kartik, you want to add on to this?
Yes, sir. Can you go back to the first slide? So, so here actually, you told palpitation as first cause and you told valvular lesion. So as per your differential diagnosis, do you think the palpitation should come first or the dyspnea should come first in this patient?
Sir, in this patient, initially it started off with palpitations and then there was a progressive dyspnea.
Okay. Then coming to dyspnea, you mentioned as NIHA. Just go to second slide.
Yes,
can you define what is NIHA? Define NIHA class 1.
Yes, sir. NIHA stands for a New York Heart Association classification, which includes 4 symptoms: chest pain, palpitations, breathlessness, and fatigue. So there is class 1 to 4. Class 1 indicates there's a presence of a structural heart disease.
Okay.
With patient has no limitation of ordinary physical activity, and ordinary physical activity do not cause any symptoms.
Yeah, very good. So that is the most important neuronal aspect. The NIHA class 1, a patient with cardiac disease with having no symptoms or ordinary physical activity. And one more thing, what we should not confuse is NIHA class 1. It does not mean that increased exertion or more than increased severe exertion causing symptoms. That is not NIHA class 1. Okay. Then you know any other classification systems? What is Canadian classification? Canadian cardiovascular classification.
Canadian CCS scoring is mainly for angina, so chest pain.
Yeah.
Wherein it is almost similar in terms of almost like similar to the NIHA classification.
Yeah.
Class 1 is structural heart disease with angina developing ordinary physical activity not causing angina. And in class 1, there is patient will develop symptoms on, the patient starts developing angina on exertion.
Yeah, in Canadian classification class 1, they will tell that the angina increases on severe exertion. That is also associated. And what is Goldman's specific activity scale?
That is based on the metabolic equivalents depending upon the amount of oxygen consumption of the cardiac myocyte. So usually a normal physical activity requires about
that also has 1, 2, 3, 4. And what are the mets? Like how many mets?
more than 7, sir.
Yeah.
More than 7, then more than 4.
More than 7, more than 5. Class 3. Type 3 is 2 to 5.
2 to 5
and 4 is cannot perform any activity more than 2. Okay. And here you mentioned the PND disappeared since 3 to 4 months, but there is associated orthopnea.
Yes,
how can you explain that with the PND disappearing and patient having orthopnea?
Yes, sir. So for PND to occur, there should be the criteria that it occurs in presence of a compliant RV. So once the patient starts developing RV failure, then the PND starts disappearing. So because initially there will be a pulmonary venous hypertension that progresses, and whenever there is PND developing, there is going to be increase in the RV has to be compliant to receive the blood, to increase the blood flow during when the patient is supine. So if the RV becomes non-compliant, then the PND can't occur and there will be reduction in the PND, but the patient will start developing the symptoms of an RV failure. So that is the probable mechanism why PND has disappeared in this patient, and the associated orthopnea is present, that is indicating a worsening of the lesion, worsening of the severity of the dysfunction.
Okay. And can this patient have cough in this before occurring this? You said RV
Yes,
failure.
Can occur, sir, because of interstitial edema, that the pulmonary venous hypertension that can cause a dry cough, because the cough receptor is present in the airway as well. It can cause a dry cough.
Yeah. Also, with sputum also it can occur, na? Pink frothy sputum and pulmonary edema, like that they describe.
Describe, yes, sir. But he didn't complain of anything like this. Patient didn't.
Okay. So you are telling a patient with, so this patient might be having some valvular lesion. That is what you told.
Yes, sir.
So a stable patient of valvular heart disease, why should he develop symptoms now? Do you think it's MS or MR?
Possibly it can be both. But because of palpitation being predominant and being regular, I'd like to consider the possibility of a regurgitation or a volume overload state.
Palpitations with the regular. Okay.
Regular.
So you're telling it's not AF.
Yes, sir. Not AF. Yes, sir.
Okay. So a MR patient decompensating like this, what could be the causes?
Sir, one possibility is he might have developed another valvular lesion. Second possibility is because of this age of 53 years, there may be a coexisting ischemic or coronary artery disease that can worsen the progression.
That is one cause. And yeah, you already discussed all this with sir. Already discussed LV dysfunction.
LV dysfunction. Yes.
And what else?
What else can precipitate a stable heart disease decompensate? The two A's, one you already told, one is arrhythmia you told, the other one is?
Anemia.
Anemia. So you could have developed a bleed somewhere. And
Anemia,
that could have, then other things which can, IHD you told?
Fever, infected patient developing an infective endocarditis can worsen.
Okay. A severe infection of any sort, infective endocarditis, correct?
Traumatic activity.
Traumatic activity. And
but age is actually, age is 53
age
years.
is 53, yeah. Non-compliance to medications. He stop the medications and then he starts. So that can again worsen the heart failure. That could be there. Fine. Go to the next slide.
Coming to the pedal edema, so patient had painless progressive swelling of the lower limbs. So initially it was there up to the mid-thigh. So this is so when we have pedal edema, common causes would be a cardiac cause, a renal disease, a liver disease. We can have a chronic venous insufficiency or a thyroid disease. Commonly, these are the commonly in practice, because there is no early morning facial puffiness and no reduced urine output is not very. So a renal cause is usually unlikely. If you have a liver disease, usually they'll have associated abdominal distension or some chronic stigmata of a liver disease or a decompensation in the form of any GI bleed. So these two are not present. I'd like to think of the possibility of this being a cardiac cause of the pedal edema.
No, in which heart disease you can
Right heart failure.
you can have first ascites?
Constrictive pericarditis can develop ascites precox.
Yeah,
And
ascites precox. Okay.
Yeah, continue.
so there is no history of giddiness or syncope. Unlikely to have an LVOT. So any outflow tract obstruction is unlikely in this scenario. But also this patient also had a component of fatigue. The component of fatigue may indicate that there is a reduction in the cardiac output. Cardiac output reduction may indicate the presence of fatigue. So with this,
You mentioned fatigue on as a presenting complaint there,
yes,
isn't
sir.
it? And then
It
fatigue
was
has
associated
been,
with the breathlessness.
yeah. So the thing
Both
is that
were
what
almost
either
simultaneous.
you
So I
shouldn't
didn't
have written it as a presenting complaint. You could have said it as an associated feature.
Okay.
Which other problem in the heart is very classically associated with exertional fatigue?
Exertional fatigue. One is aortic stenosis, mitral stenosis. Any obstruction to the cardiac output.
Fatigue is not a so prominent feature of aortic stenosis.
Stenosis.
It is syncope, angina, dyspnea.
Yes, sir.
Which valvular problem, which structural problem in the heart is associated as an exertional fatigue?
Mitral regurgitation.
Exertional dyspnea also, which we discussed that time.
Mitral stenosis can have both, sir.
It's pulmonary hypertension. Again, remember,
Okay.
pulmonary hypertension, exertional fatigue is a very, very
Common.
prominent symptom. A long-standing history of exertional fatigue with exertional dyspnea would always indicate a pulmonary hypertension. When you say fatigue, you should think of that also. Though we could have other causes of fatigue, non-cardiac causes of fatigue also could be there. Yeah.
Yes, so there is no history of nocturnal palpitation or chest pain.
Why did you ask that?
Because it can be an angina equivalence that the patient may have. Like nocturnal palpitations or nocturnal chest pain may indicate the presence of an aortic regurgitation. We had a suspicion of a regurgitant lesion, not very clear of whether it is an MRI. So like nocturnal chest pain may indicate presence of aortic regurgitation because of bradycardia. There is increase in the diastolic time, and because of the increase in the diastole, there is going to be more of runoff into the more of the regurgitation. So there's going to be reduced cardiac output to the coronaries because filling happens into diastole. So they can develop nocturnal chest pain as well.
So aortic regurgitation can have nocturnal angina.
Yes.
Yeah. Which any other etiology can have nocturnal angina? Any other cardiac disease where nocturnal angina was described for?
Syphilis, syphilitic aortitis can have.
Syphilitic aortitis. What is the mechanism of angina in syphilitic aortitis?
Ostial stenosis of the aorta.
Osteitis, coronary osteitis. There is an inflammation there. So that's where it was described for that.
In which condition you can see that ostial stenosis of coronaries? Specifically presenting in young ladies, presenting with claudication of arms.
Takayasu arteritis.
Yeah. Takayasu, they'll characteristically have this ostial involvement, left main ostium involvement, or this RCA. So all these ostial lesions are very much likely with the Takayasu. Okay. So can you tell any other angina? What is second wind angina? Or
so second wind angina is when the patient initially, once the patient starts a physical activity, he starts developing an anginal episode. After some time, he can still, on continuing the physical activity, he can still continue and there is relief in the angina.
Yeah, that is walk-through angina, right? What you're telling?
He can still continue walking is walk-through.
Walk-through. And he develops, after that, he develops the...
I think the second wind angina is, he'll take rest and after that he'll have increased threshold. The threshold is increased in this second wind angina.
Yes, probably because of that ischemic preconditioning where small brief episodes of ischemia, the patient tolerates better.
Yeah.
Other mechanism like one is the syndrome X or microvascular angina, wherein there is only going to be a microvascular dysfunction with the normal epicardial coronaries. One more is vasospastic angina, wherein patient has vasospasm predominantly affecting the right coronaries and predominantly seen in smokers in the background.
What is abdominal angina?
Abdominal angina is after, so one is it is linked with food, sir. So postprandial patient starts developing angina because of vaso-occlusive disease of the abdominal vessels.
Mesenteric vascular ischemia. So
what is unstable angina?
So unstable angina is a condition wherein the patient who's with a background of a known stable angina. Which,
no, it need not be. Background of stable angina need not be. Yeah.
May or may not be. So the patient develops a ischemic type of angina where it is retrosternal chest pain lasting for about there is no relief of the retrosternal chest pain, which is progressive in nature and not reducing and lasting for more than 20 to 30 minutes. With
Braunwald's definition of unstable angina gives 3 points. No?
3 points. No?
With less than 48 hours crescendo in nature, the severity. Right, sir?
Yes. There should be a change in the character. Severity, and it should last more frequent episodes. What you said, lasting for more than 20-30 minutes, then it becomes a acute MI or something like that. Okay, so unstable angina is cleanly defined as those 3 points which Kartik told us.
What is the main difference between unstable angina and MI? What is the difference? What is the difference between unstable angina and NSTEMI?
So in NSTEMI there is going to be acute plaque change
only one single difference. Unstable angina will have ECG changes, NSTEMI will have ECG changes.
No ECG changes and no elevated troponins.
No, ECG changes will be there.
ECG changes will be there, no troponin elevation.
Enzyme.
Enzymes will be normal, sir.
Yeah. Cardiac enzymes will be normal.
So then what are angina equivalents?
Angina equivalents are conditions where the patient, usually seen in the elderly, wherein the patient may not have frank symptoms of angina, but the patient may have diaphoresis, fatigue, nocturnal cough.
No, mainly it will have, they can present with dyspnea. They'll have neck pain, shoulder pain, epigastric pain, back pain. All these can be told as equivalents.
Okay.
What is bendopnea?
Bendopnea is a feature that is suggestive of a LV failure where the patient on bending forward for about 2 to 3 minutes, after which he starts developing symptoms similar to, he starts developing dyspnea. That is bendopnea. That indicates high pulmonary capillary wedge pressure.
Yeah, high LV filling pressures.
High LV filling pressures.
Yeah. What is blocknea?
Sir?
Blocknea.
I'm not sure, sir.
Blocknea is, they'll have, some people will have sudden choking, like sudden choking or sudden blocking of respiration and suffocation. Okay. It is also a dyspnea equivalent that's described as blocknea. I think Galavadin described it. Okay. Yeah. Do you know any scoring systems for syncope?
Syncope.
You have told for dyspnea, you told NIHA and Goldman specific activity, and for angina you told Canadian.
Yes.
Palpitation also come under NIHA. Do you any scoring system for syncope?
I don't know, sir.
What is EXIS scoring system?
I don't know, sir. I'll read it.
Yeah, you can note it down. EGSYS. EXIS scoring system. It will have some 6 points will be there where like a palpitation preceding syncope or associated heart disease or syncope on exertion. What are the precipitating factors? Based on this, they'll give a scoring system. Okay, so you can I can read it. Okay, next slide.
For the above symptoms, he was evaluated at a local hospital.
And in treatment history, you told directly patient having some valve problem and needs valve replacement. Sir, is it okay telling in exam directly?
I'm not sure if I could tell, sir.
I think you should not.
Not okay, sir.
I mean, it depends on the examiner. Some of the examiners would say okay, but then some may not.
Okay.
You're supposed to have told a cardiac disease and required a procedure, maybe.
Okay, sir.
Yeah. So he was only on that one medication which increased the volume of the urine. So he was only on diuretics.
He was given 3 medications, sir. The other details, like one was a AC inhibitor. Sir, can we mention that it was given, or
there are quite a few patients who would tell you the drugs. Okay, who would tell you the drugs.
Yes, sir.
If the patient is educated and tells you the names of the drugs, there's no harm in telling. There's no harm in telling.
Okay, sir.
So you can say the drugs have been given certain things. Otherwise, maybe that's what. If the patient tells you, there is no harm in telling.
Okay, sir. He started on AC inhibitor, beta blocker, and a diuretic. All three was
AC inhibitor, beta blocker, and diuretic. So it's heart failure is what is that. Okay.
And
again, he was admitted and he was not told to. I mean, he was not advised any prophylaxis for rheumatic fever. This happened recently, no?
Yes, sir. This was recent.
Okay, fine. Not earlier. Okay.
Not earlier.
Fine. Yeah, proceed.
Yes, sir. In past history, there was no history of fever, migratory large joint pain in the childhood, or history of any injections every 21 days. So, no penicillin prophylaxis. So we're not very clear. The patient does not remember any history of like a rheumatic heart disease that the patient might have had.
Fine.
And tuberculosis history or no contact with tuberculosis, maybe constrictive pericarditis presenting with just RV failure. But here, unlikely, based on his symptoms of
predominantly left ventricle.
LV symptoms.
Yeah. Which congenital heart disease can present at this age with you asked for recurrent respiratory infections?
One is ASD that can present at this age, sir.
Okay.
One is corrected TGA. LTGA can present at this age.
LTGA. Okay. Can you tell what is the pathophysiology in LTGA? Like how the LTGA behaves? What is it exactly? Why it's called LTGA?
Sir, in transposition of great arteries, only the aorta and pulmonary arteries arise from like aorta is arising from the RV and pulmonary artery is arising from the LV. So it is completely like a cyanotic congenital heart disease where it's going to be fully cyanotic. Whereas in this, there is also going to be the atrial concordance is maintained, but the ventricular concordance with the arterial concordance is reversed. So
no, I didn't get you. Atrial concordance is maintained. You mean what?
So LA and RA is normal, sir.
Okay.
The LA drains into the RV.
Okay.
And RA drains into the LV. And from the LV, there is going to be the arising from the aorta.
Okay. No. Why is it called LTGA? That's what I'm asking. Why is it called DTGA? Why it's called LTGA? What is the other L? What is the D?
L is like levotransposition, but I don't know why it is L. I don't know if it's
usually in the embryological period, the DTGA, it means the dextro, the looping, okay. the heart tube actually loops in the during the birth, in the fetus, yes, where the right ventricle lies to the right of the left ventricle.
Right of the, yes,
that is why it's called D. Whereas here the looping is reversed and it's a levo loop where the right ventricle lies to the left of the left ventricle.
Okay.
Okay. Yes. So the RA is connected to LV.
Yes,
so it's a AV discordance.
Yes, sir.
And LV is connected to PA. So there is a ventricular arterial discordance.
Yes.
So AV discordance, VA discordance. Okay. So yes. So why is the right ventricle, whatever the ventricle is, RA, the flow is going in the same way. But why it's called discordance Okay, we're going more into congenital. Maybe we should stop at this point. Okay, one main question. LTGA, do you think it will present in this way?
They present with more of like arrhythmias they develop, and then there's also like myocardial ischemia that this patients will have, more of like chest pain.
Most
See,
of the congenital heart disease,
LTGA usually will always have associated heart defects. Most commonly VSD.
VSD.
So it's a cyanotic heart disease. LTGA without any defects usually goes till 5th or 6th decade, and they also present with systemic failure. Why they present with systemic failure?
Because of long-standing, the LA is going to drain into the RV, and the RV cannot take so much load because it has to pump a long.
Yeah, so systemic ventricle failure.
Yes, sir.
Okay, and arrhythmias are very common. Usually, they have
atrial arrhythmias are like very common.
Yeah, complete heart.
Okay. Same with ASD also. ASD would come with more of arrhythmias and right ventricular failure, isn't it? Yes, RV failure. Yes, as a feature, not LV predominantly at that.
Yes, sir.
Which is the most common congenital heart disease in population?
Bicuspid aortic valve.
Bicuspid aortic valve. So can it present like this?
It can cause aortic regurgitation also can happen with bicuspid aortic valve. So it can have an AS with an AR. Both it can have. Defective coaptation of the leaflet can cause an AR, and because of they can also have a AS that can happen, and post stenotic they can develop a venturi that can progress, and then
most often it is secondary. Since the valve is not a normal valve, they could have an infective endocarditis, and that infective endocarditis can result in aortic regurgitation.
Yes, sir.
That would be the mechanism of bicuspid aortic valve producing aortic regurgitation. Otherwise, at around this age, it comes with stenotic symptoms. Okay.
Yes, sir. Family history was not contributory. Like there's no.
Fine, that's okay.
Yeah, it's normal, sir. Personal history. Sleep has been disturbed of late since the past 3 to 4 months, and the appetite has reduced. Bowel bladder habits, he says, fairly regular. He is not able to comment upon reduced urine output, sir. Like that would have helped us.
Gain of weight.
He didn't comment, but his family members said that he was.
That would be a feature suggestive of waterlogging. Heart failure has been there. Yes. That would be a feature.
Okay.
You are aware of heart failure scoring system, Framingham's heart failure. There are major and minor criteria, isn't it? One of the older ones it is, yes, where weight becomes the first one in both minor and major.
Can you tell the criteria, Framingham's criteria?
I don't remember this. I'll remember it.
It's quite
Framingham's
often.
You should read all this major, minor.
Okay.
Major are what? Major are PND, neck vein distension, rails, cardiomegaly, acute pulmonary edema, S3 gallop, hepatojugular reflex. These 7 are major criteria. Minor criteria, cough, pleural effusion, and these are some 2 more will be there. And the common one is weight loss more than 10 kg with medication. Okay, so Framingham's criteria.
Okay.
So based on your history, you have a 52-year-old male, isn't it, who has left ventricular failure followed by right ventricular failure. So congestive cardiac failure. So what is the possible diseases that could be there in order of frequency?
Yes, sir. Coming to because of the age and no significant contributory factors for us. So at the age of 50, I would like to consider the possibility of ischemic artery disease causing mitral regurgitation.
Ischemic heart disease per se. We don't have to have a valvular heart disease.
Ischemic heart disease.
Don't have to get valvular heart disease. The first possible is ischemic heart disease. Can it explain all the symptoms?
Ischemic heart disease. Long-standing. So initially, because of ischemic heart disease, he developed an LV dysfunction.
So there is an LV dysfunction explained and followed by a right ventricular dysfunction. That's there. So ischemic heart disease per se, without the mitral regurgitation, what any symptom which cannot be, palpitations can happen. Ischemic heart disease.
Patient may develop like paroxysmal episodes of
So you can have arrhythmias. You can have arrhythmias with ischemic heart disease also. So
yes,
ischemic heart disease per se can be explained. Forget the valvular. Okay.
yes, sir.
Second.
Second,
and what is against here? What is against ischemic heart disease? Which symptom is not there?
Which symptom which is should have been there?
Chest pain should have been there, which is not.
Yeah,
there.
angina.
Angina should have been there.
So
What
without
percentage
angina, can ischemic
can
heart
have
disease
ischemic
develop?
heart disease?
LV dysfunction like this? In which patients?
Like elderly, whenever this is like neuropathy, diabetic, or
Yeah, mainly diabetes.
Mainly diabetic patients.
Diabetics will have long-standing LV dysfunction and all.
Yes, sir.
And
angina sign Dollaire. What is angina sign Dollaire?
So patient has angina like symptoms where patient has sudden profuse sweating.
There is no angina.
No angina, but other symptoms
just
of
manifest with the spinal end organ damage. So usually in diabetics. Okay, usually in diabetics. Right.
Yeah, here one out of the box question. Some MI in a child.
Al-Kappa we have to think of, sir.
Yeah, L-Kappa. They're also 6 months old and all. They'll have directly severe LV dysfunction with severe MR. ECG showing deep Q waves in lead 1. So very likely. And also abnormal coronaries. Sometimes abnormal coronaries, they can have very long-standing ischemic effects and they can cause LV dysfunction.
Myocardial bridging, sir.
No, bridging usually will never cause ischemia. Remember that. Okay. Bridging can only severe bridging can rarely cause ischemia, but bridging usually won't cause any ischemia or myocardial dysfunction. Okay. So only severe because I have seen some cases of severe myocardial bridging where they are having collaterals from other side. Okay. So it implies that bridge is causing some form of ischemia, and we should either relieve that bridge by surgery or we can stent across the bridge.
Like just out of curiosity, like if the collateral is already developed, should we really go for a stenting, sir? Body is like, naturally try to.
Yeah, usually no. Usually bridges and all we won't tackle. Like if unless it's causing some severe ischemia and if collaterals are present, then yes, we need not. But always remember the collaterals will not completely compensate for this one. Then why we are doing CT was even CT also, if there are completely collaterals, the collateral will never completely relieve the ischemia actually. Okay. Okay.
Yes, the other possibility is considering the symptoms, I would like to think of valvular heart disease, predominantly left-sided disease, which we have. So possibility is a mitral valve disease or a combined mitral with an aortic valve disease. Although we don't have active signs of like rheumatic etiology that the patient had in the childhood, but possibilities it can be secondary to a ischemic or a rheumatic in origin, because like usually at this age group it might be a complication of a rheumatic disease that the patient may come in this 40 to 50 age group. That is one, sir. Another possibility is like late onset, like MVP with MR. That can be another possibility here.
Why not isolated aortic valve disease?
So isolated aortic valve disease reason.
What symptoms are not explained by isolated aortic valve disease?
So the
AR, as you said.
So isolated AR is rare in like rheumatic. It's only about 2%.
I'm not talking about rheumatic etiology.
Only isolated AR.
Yeah. Based on why not aortic regurgitation? Why do you want to get a mitral valve disease here?
Because they develop LV dysfunction earlier than aortic valve disease. One.
AR will develop later. AS also develops early in LV dysfunction. Within 5 years they develop.
Yes, sir.
So I don't know whether you can say mitral or MR with AR. You can say valvular heart disease, possibly regurgitant, either MR or AR. It could be both, and a shorter duration of your history, when your duration of history is short, I think aortic valve disease is aortic regurgitation per se can be there.
Sir, and still at this point, he should tell MS as possibility, right? Still, no.
Yeah. What is against your mitral stenosis as your history, guys?
Why you didn't mention MS at all?
Mitral stenosis at all when you're saying valvular heart disease?
Yes, sir. Possible MS is possible, sir. But only thing was palpitations.
The one thing that I mean, the traditionally taught or whatever it is the duration of symptoms.
Symptoms.
The duration of symptoms, if it is shorter than 5 years, is supposedly more of aortic disease that is there.
Yes.
And the duration, long-standing duration of exertional dyspnea. I mean, traditional teaching, though, you see the natural history of mitral stenosis and all will have that in that. So when in a aortic valve disease, do you suspect mitral valve disease? If the duration is more than 5 years.
More than 5 years. Yes,
so that is what has been told and taught. So per se, I think valvular heart disease, since you're saying it's a shorter duration, if your duration is very clear and you're not considering rheumatic, then possibly AR or MR isolated is okay. Otherwise, if you want to get rheumatic, MS has to be there. MS has to be there.
With coexisting.
Yeah. One more thing in history you can ask is what was his occupation?
Okay.
What was his occupation? Did he change his occupation 5 years back or 7 years back? All those things will tell you whether there was something else there. So the patient may not tell you that he had dyspnea, but did he change an occupation that required more activity? He has changed it to something. So that will give you a clue whether the disease existed prior to this 1 year.
Okay.
Here your symptoms all is 1 year only.
1 year is.
So you have to ask what occupation, did he change his occupation? Why did he change his occupation? That can give you the longer the history. So more the longer, mitral valve disease is absolutely more likely. Otherwise, short, your MR and AR is possible.
Yes.
And VPMR will only come when discussion happens. Otherwise, it won't come as it is.
Yes, sir.
Which is
and what percentage of? Please, sir, you carry on.
No. You ask. Next.
What percentage of patients of rheumatic heart disease will have no history of all this? No history of rheumatic fever? No history of any symptoms?
I'm not sure, sir. Can I take a guess, sir? I don't know the exact value. Is it like 7.9 to 8.7?
No. More than 50%.
Much. 50% and above.
50% will not have any.
Above will not have give you the history. Okay, they will not give you the history. Why do you think it is like that?
Because the symptoms are going to occur very transiently, sir.
Not transiently. Rheumatic fever significant will be there. But occurs much earlier. Supposedly, your 5 to 15 years is where your age group is. They might be very young that time. They may not remember. And again, remember all the manifestations of acute rheumatic fever may not be there in the patient. It could be just coming as an indolent carditis itself, which can have a significant effect. So they say almost up to 50% will not give you the history of rheumatic fever.
Can you tell me what percentages can this occur? MR with AR, MS with AR, which is most common? Which is most common?
Mitral stenosis is most common.
Okay.
After that, we may have after the mitral valve involvement, it takes about.
No, I'm asking only multivalvular. Multivalvular presentation, which is most common. MS with MR or MR.
MS with MR is more common. So MS with MR is more common.
Okay.
Followed by that, it is going to be
which aortic
valve involvement, sir. Like
which one?
AS is going to happen, then AR.
No. First, most common is MS with MR. After that, it is MS with AR.
MS with AR, then AS with AR.
No. After that, MR with AR.
MR with AR.
Okay, sir.
What combination is not so likely to happen with mitral stenosis?
MS with AS, sir.
MS with AS?
No.
The other one that we told already.
MR with AR.
MR, the LV will be dilated. AS, the LV will not be going out. So the LV will go into burst out, something like that. So AS with MR is not I mean,
Okay.
significant
It's only,
AS and significant
it's only
MR is
0.3%. MR with AS is only seen 0.3% combination. And which is the most worst combination of all this?
AS with MR, sir.
Yeah.
AS
Yes,
Teacher
with
always
MR.
tries to protect
High
us.
pressures in the
AS with MR, because there is no forward output,
forward.
and whenever the heart tries to contact, the blood goes into LA.
LA.
So AS with MR is one of the worst combination.
Where to read this percentage, sir? I couldn't find it in.
It will be there in all these books.
But
Rheumatic heart disease, many articles are there. You can read
more
this.
of articles that is there.
Like book I couldn't find. Like I read through Brownwald, but it is not so clear with.
These are all the Western books, isn't it? Be it even the oldest Samuel Oran is also Western book.
You can read this. You can read this. You can write something actually. Anita Saxena series, Indian Heart Failure Registry series, 2014 one series is there. There you can read.
Okay, sir.
One AIMS, one sir is there, Ramakrishnan sir. His book is there, one Cardiology Clinical Methods. There, in that everything is written. That's actually one CMC Velour Jacob Jose sir's notes. In that everything is written. All these are given.
Okay.
Before valvular heart disease, after ischemic heart disease, any other disease you want to consider which can cause left ventricular failure at an age of 50, 55? You said ischemic. Second should be undiagnosed.
Rheumatic.
Rheumatic is anyhow valvular. No?
Valvular.
Hypertensive heart disease.
Hypertension can cause, no?
Okay,
Hypertension.
yes, sir. Hypertensive heart disease.
At this age, we should keep that also.
Yes, sir.
Though your examination findings would go towards the other things, but ischemic hypertension should come at this age because undiagnosed hypertension can produce these symptoms. Then you said valvular, and then you are told about dilated cardiomyopathy.
Yes, sir.
Why dilated cardiomyopathy?
It may be like indolent initially, and like this some forms of like idiopathic DCM, they present with about like 40 to 50 years they can present. So they can have
anyhow would have had the symptoms and would have had the procedure and all done and all those things. What are the conditions where you get non-ischemic DCM?
One is that LV non-compaction.
More commoner ones. Some etiologies where the heart gets dilated.
Myocarditis, like subacute to chronic myocarditis, that patient may have.
Common ones, more commoner, which we see often. Toxin.
Toxin.
Alcohol, isn't it?
Alcoholic.
Very common. Alcohol.
Yes.
Alcoholic
Diabetic
patients. Alcoholic patients. Then sometimes your vitamin B1 deficiency.
Very, yes.
Yeah. Peripartum, postpartum status and all this. So they can also cause that.
And read about stress cardiomyopathy. Stress cardiomyopathy also very important. Very common than what we think.
And here you have one within a year it has progressed downhill. So you have to think of that acute events, what can cause that. Stress cardiomyopathy is important. ASD, can it explain all these symptoms? You put congenital heart disease, ASD.
No, I just put it in the end, sir, but it does not cause LV failure. It causes more of
predominantly LV failure. There is no palpitations, etc.
Yes,
so ASD should be removed totally.
Okay, sir.
Okay. I think we'll go to the examination.
Yes. Coming to the examination, I have a middle-aged male patient, conscious, cooperative, oriented to time, place, and person, lying on the bed. Weight is 66 kg, height is 164 centimeter, BMI of 24.53 kg per meter square. Upper segment.
Slide has changed, Vijay. I think the slide is not changed.
Sir, okay, 1 second, sir. Okay, I think.
Yeah.
Sir, weight is 66 kg, height is 164 centimeter, BMI 24.53 kg per meter square, upper segment 78, lower segment 86, arm span of 168
Sir,
centimeters.
some members are raising hands and all, like
I
they
think
want
we'll
to
take,
ask anything.
yeah,
Or?
we'll take the questions. I think then we'll go on to examination.
Okay, sir.
Let's see. Yes. Raghu, what is the question?
That's what.
Raghu, you raised your hand.
Yeah. Maybe by mistake. Then.
I
Okay.
think it's okay.
Okay, then you can go on.
Yeah, you can proceed.
Okay. Upper segment 78 centimeter, lower segment 86 centimeter.
This patient has edema?
Sir, I've examined here, sir. Pedal
No,
edema.
edema is there or no?
Yes, sir, it's there, sir. Pedal edema is there.
BMI calculation is not needed.
Not
you can just
very
mention the
reliable here.
yeah, height and weight you can mention. BMI is not needed.
Okay, sir.
Yes. What's the relevance of other measurements that you have?
Sir,
Upper
one is
segment.
yes, sir, upper segment, lower segment ratio will indicate usually it should be 0.8:1, sir. 0.8:1 is the normal upper segment, lower segment ratio. If the upper segment by lower segment ratio is increased, then we have to think of Marfanoid habitus or Marfan syndrome.
Marfan syndrome, what is the basic criteria? First thing, what should be there? The height should be more than?
Your voice
height
is
should be more.
not clear.
Sir?
Hello?
Yes, sir. Yes, sir.
Kartik, it's clear?
Yes, sir. Audible, sir.
Yes, sir, it's clear. No.
Yeah. See, Marfan's, 180 centimeters. Only once the height is really tall, then we should consider Marfan syndrome. Yes, you can have Marfanoid habitus. That's a different thing.
Yes,
but in a Marfan syndrome, possibly you'll have to take the measurement.
okay, sir.
Somebody who has not 180 centimeters and more, I think we should not be.
Not required.
You can take the measurements, but don't volunteer it straight because direction of entire thing will go haywire. Then. So they may say, what are the conditions where you have short stature and then there is Marfan syndrome like features, and it will go on to all your congenital heart disease.
Okay.
You can take the measurement, but do not volunteer it upfront.
Okay, sir. Pulse rate, it was 78 beats per minute in the right radial artery, regular in rhythm, high volume, collapsing in nature, with all peripheral pulses being well felt with no radial or femoral delay. The blood pressure in the right upper limb was 130/40. Left upper limb was 120/50 millimeter of mercury. And both the lower limbs was 210/50 millimeter of mercury. So here we have respiratory rate was 14 cycles per minute, thoraco-abdominal type. Saturation was 98% on room air in all four limbs. Temperature was 98.4 degree Fahrenheit. JVP is abnormal, 7 centimeter above the sternal angle at 45 degree with a prominent V waves. Hepatojugular reflex was negative. Coming to the
low limb blood pressure, diastolic. How did he calculate that? How did he check the low limb blood pressure?
I didn't use the popliteal. I didn't have the cuff for checking the popliteal.
Yes.
I used the cuff and I took the pulse at the level of posterior tibial artery.
You could auscultate there.
Yes, sir. It was very palpable. You could auscultate this.
When we're using the same cuff and we're checking for the dorsalis pedis or posterior tibial, systolic is sufficient because for your Hill sign, systolic is sufficient. Because to get this auscultate, I mean diastolic by auscultation, we have to auscultate popliteal. That's traditional. We do not have that cuff. So the cuff which you're using for upper limb can be used at the calf, and you can palpate the dorsalis pedis or the posterior tibial. And if you get the systolic blood pressure in the lower limb is fine. Okay. You don't have to get the diastolic. So it's better to say 210 systolic.
Okay.
So what's the relevance?
So this indicates that there is increase in the lower limb blood pressure than the upper limb. So coming to upper limb blood pressure, sir. So there is a wide pulse pressure first, wherein the pulse pressure is more than 40. This indicates a high volume pulse. First thing, sir. High volume pulse is going to indicate high output state or volume regurgitant lesion. The another possibility that is one, sir. And comparing the upper limb to the lower limb, we have the Hill sign, which is positive. traditionally described for aortic regurgitation, wherein the difference between the upper limb systolic and the lower limb systolic. If it is more
When
than
do you say a high volume pulse is collapsing?
collapsing, yes, sir.
When do you say a high volume pulse is collapsing?
Yes, sir. So when we say high volume pulse collapsing, when there is a sharp onset, peak with rapid runoff.
Okay. So how do you objectively say that this is collapsing? Collapsing is a word which we more often use it for aortic regurgitation. What is the prerequisite to say that it is collapsing? Not all high volume pulse are. High volume means wide pulse pressure.
Wide pulse
Correct?
pressure.
So to say collapsing, what else should be there along with wide pulse pressure? To get the classical collapsing pulse, what else should be there other than a wide pulse pressure?
Peripheral runoff should be there.
So the diastolic blood pressure should be
low,
less than 50.
50.
So if you have a diastolic blood pressure less than 50, definitely it's a collapsing pulse. So you should be able to demonstrate it. I think that's a very common question they ask you in your clinics, to demonstrate the collapsing pulse. Can you describe?
So we place one arm over the, first we feel for the pulse, the radial pulse, and one arm over the um, wrist, and the other arm at the level of the elbow, sir, where the brachial is present. Like I have this confusion, sir. Two ways in which we are taught. One is some say one hand at the level of the wrist and one at the level of the elbow, and you feel for the runoff once you raise the hand. Other is the one is at the level of wrist and one is the other arm just below it, and then you lift the hand. So which way
the
to?
thing is, it's a high volume pulse, so all your pulses are going to be very well felt in this patient. So what you're supposed to do is palpate the radial, keep going proximally till you are able to just feel the radial.
Okay.
Normally, you will not be able to feel the radial maybe after 2 to 3 centimeters, but in aortic regurgitation, you'll be able to feel the radial up to the elbow. You might be able to feel it right till there. So what you're supposed to do is you're supposed to go as distally as possible there. Sorry, as proximally as possible. And then the part of the hand that you're going to place there, which part of the hand you're going to place there? The metacarpal heads.
Metacarpals.
So this part you're going to face. Okay, the one which we use for thrills. That part we are going to enclose at that part there. And then we are going to raise. Okay. Then we are going to raise it. And what will happen when you raise it? You raise it above the shoulder there. Some say hyperabduct and raise. What happens?
Initially, there is going to be the pulse that we feel. Then there's going to be a rapid fall, and then again you get the.
Okay, again, see, normally do you feel the pulse well when you raise your hands? Is the pulse felt well?
Not very well, sir.
Normal pulses may not be felt so well. But here in aortic regurgitation, it will be a bounding pulse, so you should be able to feel it. So simultaneously, with the other hand, you're supposed to encircle the wrist. This is one of the traditional ways. I think that's how Somaraju and this have given. So encircle the wrist. So with the other hand, encircle the wrist. One hand will be at this part. So you're raising it. So what you feel is at the distal part, you'll be able to feel the thud which is coming. That's a very high volume pulse that is going to come. And with the metacarpal heads that you're placing, you'll be feeling the diastolic runoff going down. So that is one traditional way of this one. The keeping at the wrist is plus minus, but it is better to do it because quite a few of the examiners would always would believe in that. There are some feel that even ulnar artery will be felt in that. Normally ulnar artery is not very felt. When we encircle the wrist, both the radial and ulnar is felt, which can be only seen with severe aortic regurgitation. Okay? So you may not feel it in other things. So yeah, as you said, there is a little discrepancy on the method how you're doing it. But what is important is you place the metacarpal heads at the point where the artery is just felt, and then you raise. So you're raising it in an attempt to make a supposedly a straight column of blood right from the aorta up to the carotid. It's like a straight column of blood which can come and drop back. That's why you hyperabduct and raise. So that's the mechanism. Yes, I do agree there are different proposed mechanisms, but this is how it could be done, satisfying most of the examiners. So each of them would have their own preferred method, but by combining the good part of all, maybe you can sail through there. But this is asked in exam, so you have to very clearly do it clearly. Again, it's preferably done in sitting position. Do not do it in supine because you can't raise it up like that. So it's preferably 45 degrees. Okay, whenever the examiner starts the exam, put the patient in 45 degrees with the backrest. So you can do all these things easily in that way. Dr. Kartik, your comment on that? Collapsing pulse and demonstration.
Yes, sir. Fine, sir. Whatever you told is.
Because this is asked. Okay, I don't know what is this one about it, but yes, this is asked and often asked to demonstrate right from your undergraduate to
Yes.
maybe to the time. So each of them have their unique method. So there is nothing that can satisfy every one of them.
Like in exam, if they ask, how do you say, sir? Like, how do you know which is correct? Like, because it's so variable.
No, it's how confidently you say it. That's all.
Okay.
It's all.
Okay.
Examiners would agree to majority of it. If they don't agree, say sorry. That's okay.
Okay.
Doesn't matter. Any other way to confirm that it is truly collapsing? You have a wide pulse pressure, diastolic is around 50. Any other way to confirm whether it is truly collapsing? Because if that you do it, then the examiner also has to agree that this is collapsing. Any peripheral signs of aortic regurgitation which can be?
Yes, sir. One is the
BP cuff.
If there is this like Dorosios, the other peripheral signs, if they are there, sir.
No, those things are agreed. I said with the BP
Hills-
cuff, with the BP
Hills
cuff,
sign.
other than Hills, what else can we do? Hills is correct. What else can we do with the BP cuff with aortic regurgitation? In the upper limb, any other sign you're aware of?
Main sign where I'm not very aware of what it is, sir.
Supposedly, I get a blood pressure of 130/40 in keeping the hand like that, and then I raise the hand.
Okay, sir.
Hello.
Yes, sir. Yes, sir. You're audible, sir.
Yeah, when you raise the hand. Yeah, when you raise the hand. So normally the diastolic should go off because in aortic regurgitation sometimes you can get diastolic to 0.
0. Yes, sir.
But you can get a diastolic sound there at around maybe 40. And when you raise your hand and you start hearing the Korotkoff sounds again, and then the diastolic drops by more than 15. Okay, that's supposedly a confirmatory test that it is truly collapsing. Again, this is Western literature. We do not have this one for it, but yeah, it's a described sign of, it's called as main sign, as you said. So on raising, if it drops for more than 15. But yes, more than if your diastolic is less than 50, then it should be collapsing only. Yes.
And based on this, like we can quantify the severity based on Hill sign where it is more than 20 significant. Here it is more than 60, which is significant of a severe AR.
It says it is severe aortic regurgitation so far. Okay. Is mitral valve disease there or no?
Sir, possibility of mitral valve disease is present because the upper limb BP, we expect systolic to be little on the higher side in an aortic regurgitation.
Not necessary. That aortic valve, aortic stenosis can be there.
Yes, sir.
What in the pulse, etc., would tell you that there is definite coexisting mitral valve disease, maybe? It's not there in this patient, isn't it? Irregularity. If there was AF, definitely the possibility would have been there.
Yes, sir.
And JVP in isolated aortic valve disease?
It is going to be like isolated aortic valve disease usually does not cause much of involvement of the RV, sir.
Yeah, unless there is a heart failure. Here
Heart
your
failure
patient has heart failure, so the JVP elevation. Yeah, so JVP elevation is there, possibly due to the heart failure also, because you said hepatojugular reflux is negative. So what does that hepatojugular reflux negative mean to you?
Sir, it means that there is no imminent heart failure. So the hepatojugular reflex is going to indicate imminent right heart failure and not a frank RV failure. So if the patient is going to go into an RV failure, early RV failure, then we can have this hepatojugular reflex being positive.
What do you mean by negative?
It's not negative, sir.
Negative hepatojugular reflux, which condition are we talking about?
It should be a like SVC thrombus. like that. It should be
Some
not
obstruction, isn't it? Budd-Chiari or something like that.
Budd-Chiari, yes, sir.
It's unlikely. So here in RV failure, what's the word you want to use? Hepatojugular reflux is
Absent, sir.
absent. No, absent means it's not there.
Not there.
Can you describe the hepatojugular reflux?
Yes, sir. So we apply pressure over the right hypochondriac region, patient being supine of 45 degrees, and we look for the rise in the JVP, the sustained rise in the JVP of more than 5 centimeter and for pressure more than 3 minutes.
3 minutes? Do you have to keep pressure for so long? So what are you doing by pressing onto the abdomen?
We are increasing the we are increasing the output, venous return to the heart, sir.
Okay, so anything coming to the heart, how fast the heart will correct it?
Correct it, yes, sir.
How fast will it correct normally? Any change happening in the heart?
About 15 to 20 seconds, 10 to 15 seconds, within that time it reduces.
Generally 10 to 15 is also a large number. Okay? Please remember the heart can correct things within 3 to 5 cardiac cycles.
Okay.
What is 3 to 5 cardiac cycles?
3 to 5 cardiac cycle is 0.8 into
cardiac
3.
Cycle is 0.8.
0.8 into 3. 2 to 3.
Less than 4 seconds.
Okay, sir.
So less than 4 seconds, the heart will easily correct it.
Correct.
If the heart is normal, isn't it?
Yes, sir.
So that is the basic thing of the heart. So supposedly the heart is normal, the JVP has raised. You're pressing here 15 seconds. What should happen to the JVP?
It should fall. Initially there will be rise and then it should be fall.
Yes. So please remember the hepatojugular reflux, or it's better called as an abdominojugular reflux. It's not hepatojugular alone. So it's abdominojugular reflux. We say it is normal if there is a rise of 4 centimeters, which falls within 5 to 5 cardiac cycles. So it should fall back. That is normal. If it remains elevated, like what you're expecting in your patient, when the RV is failing, RV compliance is decreased. So what do you call that hepatojugular reflux as?
Sustained.
So what you're supposed to write is sustained abdominojugular reflux.
Yes,
Moment you say negative, it means there is no connectivity there. It means a Budd-Chiari syndrome.
Yes, sir.
So the word is very important. Unless, see, again, it's not necessary. Nobody is going to ask you about abdominojugular reflux. If you volunteer, then you have to know everything about abdominojugular reflux, who described it, when was it described, what are the modifications, everything will go.
Okay, sir.
So you have to know thoroughly. It's a very important sign. Even if you don't tell, they can take you there. But when you say, you have to tell it very clearly.
Yes, sir.
And V waves and all, have you mentioned V waves? Like, how can you say V waves?
Sir, we time it to the cardiac cycle, sir. So I timed it with the carotid.
Okay.
So whenever it is V wave is going to occur along with S1, simultaneous with S1.
Okay.
The prominent.
Better word would be simultaneous. It is not actually simultaneous. It is
like
better word.
It is immediately after S1. Sir.
Synchronous. Always use the word synchronous in cardiology. Synchronous with the carotid or synchronous with S1. So what comes synchronous is V wave. Okay.
Yes.
Right.
Head to toe, there was mild pitting pedal edema. This was examined after 1 day after the patient was admitted. So the edema had reduced after the diuretic infusions. There's no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. There's no signs of infection.
I think you can hear. You just mentioned pedal edema present. That's all.
Yes, sir. Pedal edema present. Sir.
Mild and all.
Mild not required.
Pitting pedal edema. Fine.
Okay, sir.
Yeah.
Coming to the peripheral signs of AR, there is a dancing carotids or the corrigans, the collapsing pulse, the pistol shot in the femorals, the Derosios murmur, which is both like the to and fro murmur both, with the Hill signs positive. There's a carotid trail.
Of those signs, you know.
Yes, sir. Dancing carotid is. Sir, should I tell like head to toe?
No. These ones which you told each other.
Dancing carotid is a corrigans. Collapsing pulse is water hammer pulse or collapsing pulse.
Watson's.
Pistol shot femoral is Traub sign, and Derosios murmur and the Hill.
What is piston short radial called?
I don't know, sir.
Palfrey.
Palfrey.
Okay, sir.
There are many other signs, but of relevance for the disease, which is the signs which are relevant.
Hills is
sign,
relevant.
one.
Collapsing pulse is relevant.
Hill
And
sign is
Durosius
definitely
murmur is
relevant.
having high specificity.
Yeah. Durosius supposedly has a correlation with
diastolic.
Severity part. What are the aortic regurgitations where you may not have peripheral signs?
Coexisting LV dysfunction, coexisting aortic stenosis, coexisting mitral stenosis, severe mitral stenosis.
Coexisting mitral regurgitation.
Yes, sir.
MR.
MR, yes, sir.
And acute aortic
Acute AR.
You may not have.
Acute AR.
May not have this. Okay.
What is the reason for that low diastolic pressure in the aortic regurgitation?
Sir, there is a peripheral runoff in the diastole, sir, because the aortic regurgitation is going to happen in the diastole. Because the valves are going to close during the diastole. The semilunar valves close during diastole.
No, that's what I'm asking. Why there is peripheral runoff? The problem is at the level of heart, right?
Yes, sir.
Why should be there a peripheral runoff? Whatever the blood artery is contracting in the aorta, it is coming back into the LV during the diastole.
Yes,
Why there is a peripheral runoff?
Secondary probable vasodilatation that is occurring, sir.
Why there should be a peripheral vasodilatation?
What's the volume? What's the volume that is coming out in aortic regurgitation?
The volume of blood is huge, sir. The vent Kessel effect, wherein initially there is going to be the elastic artery that accommodates for
large volume of blood which is coming out stimulates
stimulate baroreceptors,
carotid baroreceptors.
Vasodilatation.
So simple.
Because of baroreflex, there is reflex peripheral vasodilatation.
Reflex vasodilatation.
So there is carotid baroreceptors which is stimulated by the large volume of blood coming out. And as you said, diastolic runoff is into the LV, not into the periphery. Periphery is secondary to vasodilatation. Okay. It could be one is due to the baroreceptors, other one is secondary to the decreased systemic vascular resistance. So that is why you get this collapse. Yes. Continue.
Yes. Coming to the cardiovascular system, the trachea is central, the chest is bilaterally symmetrical, there is no precordial bulge. The apex beat is present in the left sixth intercostal space, 3 centimeter lateral to the mid-clavicular line, hyperdynamic in nature, LV type with medial retraction. There is no parasternal heave. Suprasternal pulsations are noted and epigastric aortic pulsations were seen. Were felt. There's a palpable P2 in the pulmonary area. There's no other pulsations or thrills, no dilated veins, scars, or sinuses.
So what's your inference so far?
So based on this inference, we have a down and out apical impulse suggestive of a volume overload. Probably it should be a chronic lesion. So there's a chronic valvular heart disease, probably a regurgitant lesion.
It does not say chronicity. Okay, it says that there is a, as you said, volume overload of the left ventricle.
Yes, sir.
Okay.
Being hyperdynamic, again, it is volume overload.
Okay.
Then the LV type localizes it to the left ventricle. The other thing is the presence of suprasternal pulsations. So whenever there is an aortic disease, you can have prominent pulsations. And epigastric pulsations.
Aortic regurgitation, you can have that. Palpable P2.
Second, suggestive of a pulmonary hypertension, pulmonary arterial hypertension.
Pulmonary hypertension, okay. Pulmonary arterial dilatation. Okay. So that means that there is, if you have in a patient with aortic valve disease, there is a pulmonary hypertension. That means there is a. It indicates what? You have an aortic valve disease which has pulmonary hypertension. What does it indicate?
Severe.
It indicates there is a coexisting mitral valve disease.
Mitral valve disease. Yes, sir.
Okay. Coexisting mitral valve disease. So in the history, I think we discussed that
Yes,
The
sir.
3 characteristic features to find out a coexisting mitral valve disease in a aortic valve disease. One is duration of symptoms more than 5 years. Second is AF, and third is presence of pulmonary hypertension.
Okay.
So if these 3 are there in a aortic valve disease, then you can consider coexisting mitral valve
Mitral
disease.
valve
Where your palpable P2 is there, so you could have a coexisting mitral valve disease also.
Yes, sir.
And here they can ask what are the causes of parasternal heave?
Heave.
Which
Yes, sir.
chamber enlargement can cause parasternal heave and all?
Yes,
So
sir.
can you
So,
tell?
yes, sir. Parasternal heave can be seconded to 2-chamber enlargement. One is the RV, one is the LA. So to distinguish these two, we look at the timing in the cardiac cycle. So if it is the RV, it is going to be in systole. If it's the LA, it's going to be in the diastole.
Okay. Synchronous with the apex and asynchronous with the apex.
Apex. Yes, sir.
LA will be asynchronous.
Asynchronous with the apex.
Again, parasternal heave, it would have been there. It would have been more stronger feature of a pulmonary hypertension that would be there. That's not there in your patient.
Yes.
Okay, next.
Coming to percussion, the left heart border corresponds to the apex. Right heart border was retrosternal. The left second intercostal space.
Better to say right heart border to the right sternal edge.
Right sternal edge. Okay, sir. Left second intercostal space was had an impaired note on percussion. The liver dullness was in the right fifth intercostal space in the mid clavicular line. A trough space is tympanic to percussion. This indicates that there is pulmonary hypertension without any cardiomegaly.
There is cardiomegaly by the apex already. What is there no cardiomegaly?
There's no effusion here.
That does not. You don't have to infer so much things from that. Cardiomegaly is done by palpation.
Palpation.
Already palpation. There is no there is huge cardiomegaly.
Huge cardiomegaly. Yes, sir.
What are the causes of left second intercostal space impaired note?
Sir, one is the pulmonary arterial hypertension, pulmonary artery dilatation.
Dilatation, idiopathic pulmonary arterial dilatation.
Dilatation.
Third one, aneurysm of the pulmonary artery.
Pulmonary artery. Okay, sir.
You could get it in other conditions, respiratory causes also, but these are the cardiac conditions. So impaired note does not necessarily mean it is pulmonary artery hypertension.
Okay, sir.
But yes, you have palpable apex that you palpable P2 you told, so it could be pulmonary artery. Okay.
Coming to the auscultation, sir, coming to the mitral area, the S1 is soft. There's a grade 3 out of 6 high-pitched, soft-blowing pansystolic murmur present at the apex, relating to the axilla, best heard at the diaphragm of the stethoscope in the left lateral decubitus position, with breath held in expiration. There is no S3 or S4. Coming to tricuspid area, the S1 is soft. There's a grade 3 out of 6 high-pitched, soft-blowing pansystolic murmur at the apex. It's not relating to the axilla, sir. There is no radiation of this murmur. It is present in the lower left sternal border. Best heard at the diaphragm of the stethoscope, breath held in inspiration, and it increased on the passive leg raise. Pulmonary area, coming to the auscultation of the sounds, the pulmonary, the second heart sound in the second heart sound was loud. To call it loud, like I compared it to the compared in the aortic area and the pulmonary area, where normally the aortic sound is heard more prominent in both. When the pulmonary is heard as equal to the aortic, then we consider it to be loud. So it's a loud P2 with a wide S2 split. Then there's a grade 3 out of 6 ejection systolic murmur in the left second intercostal space, diaphragm of death, patient sitting and leaning forward, breath held in inspiration. Increase on passive leg raise. Coming to the aortic or the new aortic area, the S1 is heard, the S2 is soft. There's a grade, the two murmurs. Sir. One was the grade 3 out of 6 high-pitched, soft-blowing early diastolic murmur in the right second and left third intercostal space, which is the new aortic area, which is decrescendo in nature, extending to more than half of the diastole. Best heard at the diaphragm of the stethoscope in the sitting up and the leaning forward position, with breath held in the expiration. Along with that, there is also a grade 2/6 ejection systolic murmur in the left second intercostal space. Right second, sorry, so this is in the aortic area, sir. The right second intercostal space. It had an early peaking, and it was heard with the diaphragm of the stethoscope, Patient was sitting and leaning forward, and the breath was held in expiration, and this sound conducted to both the carotids. So coming to the inference of all these, so in the mitral area, we have the soft S1 with a pansystolic murmur in the axilla and in the apex and radiating to the axilla. So this is indicative of a mitral regurgitation, sir, because there is also increase on breath held in expiration.
So this is mitral regurgitation. Why not its aortic stenosis?
Usually, if the aortic stenosis is there, usually it doesn't radiate to the axilla, sir. It's usually
does not radiate to the axilla. Fine. Okay. So this is mitral regurgitation.
Regurgitation. Yes, sir. And coming to the severity of this, there is no S3 or S4 that could indicate. No S3. S3 is an indicator of severity. So there's no
Later
S3.
For the valvular heart disease, just the murmurs you tell.
Yes, sir. Okay, sir.
This is mitral regurgitation.
Yes, sir. In the tricuspid area, there is a tricuspid regurgitation, probably a functional TR. Coming to the pulmonary area, there's a pulmonary hypertension with a wide split, probably a secondary to a high pulmonary hangout interval because of the pulmonary arterial hypertension and increased time for the valve being open. And
so splitting, widening of the split is a feature of pulmonary hypertension.
Yes,
you said widening of the split. Is it a feature of pulmonary hypertension?
Because of the increase in the resistance, there is going to be the valve will be open for a longer time.
No, with the resistance, the valve closes first. When you have significant pulmonary hypertension,
because of
what happens
RV failures, the hangout interval drops because of low compliance. The hangout interval drops, and it should ideally close faster. Sir.
When you say the wide, when you're saying a wide split there, and
yes,
this patient has pulmonary hypertension, you have P2 palpable, etc. It indicates that there is increased flow in the pulmonary.
Can it be secondary to the RV failure? So, high pressure in the RV diastolic, RV pressures, high systolic pressures, and then that increasing the hangout interval.
Unlikely. What I think it is, whenever there is pulmonary hypertension, the split should narrow. If you're saying the wide split is present, that goes straight in the favor of AST. Dr. Kartik?
Yes, sir. Wide fixed split is a feature of AST. Whenever if you say the split should be fixed, that is what should not vary with respiration. That see, whenever you are commenting about P2, you should always tell about how is the A2 component, or about second heart sound. Sorry, when you're telling about second heart sound, you should describe the both components. What is the intensity of them? What is the split between them? Is it narrowed or wide or fixed? Okay.
Okay, sir.
So that is the most important.
Okay, sir.
And one more thing is regarding your valvular lesions. What happens to split in MR? What happens to split in AR?
Yes, in MR, there is going to be early A2, so there is going to be a wide split, sir.
Early A2.
Because there is going to be regurgitant amount of blood that is going, the duration of which the aortic valve remains open is going to be reduced because of the regurgitant jet that is going.
Okay.
So the A2, the early A2, and then there's going to be a wide split.
Yeah. Okay. In AR?
In AR, it's going to be a single, the single S2.
Yeah, split may narrow or
maybe single.
Single. Okay.
Rarely it can become paradoxical, because of the high, again the hangout interval increases and then it becomes paradoxical.
Okay.
Yes, sir. Coming to the pulmonary area, there is a pulmonary hypertension murmur, sir. Coming to the aortic and neo-aortic area, in the neo-aortic area, we have the murmur of the aortic regurgitation, which is an early diastolic murmur. And because it is going more than half of systole, so probably it's moderate to severe, may indicate the severity.
Half of diastole.
More than half of diastole, sir. More than half of diastole.
Hollow diastole.
Yes. And the other thing is presence of this systolic murmur. Presence of systolic murmur, the only thing is with the significant amount of AR, other possibility for this should be either it can be an aortic stenosis, or it can be a severe AR itself, sir, because of the increased flow. Because of the early peaking of the murmur, so I'm thinking in terms of more in terms of a severe AR rather than and causing an increased flow across the aortic valve rather than a stenotic.
You say that's a flow murmur of AR.
Murmur, yes.
Flow murmur.
So total, how many murmurs you had? What at mitral? Mitral?
I
What
had
are
an
the murmurs?
MR murmur, sir. In the tricuspid area, there is a TR. It increased in inspiration, and it's radiating to the right side. Pulmonary area, there is a pulmonary arterial hypertension.
No, you didn't have any mitral diastolic murmur.
I couldn't appreciate the MDM in the mitral area, sir.
Okay. What are the causes of MDM?
So one is the mitral stenosis, tricuspid stenosis. One can be a flow obstruction. So it can be the LA myxoma or a ball valve thrombus of the mitral valve.
Okay.
The other possibility is the presence of an Austin Flint murmur, wherein it can be a functional MS because of regurgitant jet in this one. Or another possibility is there can be a fluttering of the mitral leaflet. Another possibility is
which condition is that? Fluttering.
So in AR only we can get both.
Oh, that's Austin Flint over. Next cause for mid-diastolic murmur. One more named murmur.
Complete heart block, sir. Right hand murmur.
No, commoner one. Acute rheumatic fever.
Acute rheumatic fever, that Carey-Coombs murmur.
Carey-Coombs murmur. Carey-Coombs murmur is also mid-diastolic murmur. Yes. Then, but the other flow murmurs in the mitral and tricuspid valve. Common. Which are the diseases?
Severe anemia.
Severe anemia can be there. Severe AR can be there.
MR.
Severe MR.
Severe MR can be.
Your shunt lesions, ASD, VSD, PDA.
Yes, sir.
They are common. They are, you can
cause increased flow. Yes, sir.
Diastolic murmur across mitral and tricuspid. This list you have to know. This list you have to know. Okay.
Will this Austin Flint murmur describe any severity here?
Does it indicate
presence of MDM indicates severity in AR, sir? Yes. So it indicates a severe AR. Presence of an MDM.
Yeah, Austin Flint indicates severe AR.
Severe AR.
I'm not able to appreciate, sir.
Fine. What else should have been there?
And even your MR also to say severe. Definitely there. Usually there may be an
flow MDM.
Associated flow MDM.
Flow MDM. So that's also not there. What else should have been there if Austin Flint would have been there? Any other thing you could have had? Austin Flint murmur is introduced by what? We say mid-diastolic murmur of mitral stenosis is introduced by?
Opening snap.
Opening snap. Similarly, Austin Flint is introduced by? What is that sound which comes exactly there next to OS?
Ejection flick.
No, diastole.
You didn't mention third heart sound and fourth heart sound anywhere.
You said no S3.
No S3, sir.
There's written no S3 in one place.
Oh, no S3. Okay.
No S3.
Austin Flint is introduced. Austin Flint is introduced by S3.
S3.
So even if you have an S3, you can say that there is severe AR. AR could be there. So unless there is other cause that you have.
And even severe MR also
will have.
Will have S3.
Will have S3.
S3.
So cardiomegaly and S3, if it would be there in both, it says severity. Okay.
Yes, sir.
Aortic, your diagnosis is AR with the functional aortic stenosis.
Functional, yes, sir. Functional, yes.
Okay, what is your final diagnosis? Next.
Sir, acquired valvular heart disease, severe AR with possibly a moderate MR, with functional TR, probably probable rheumatic etiology, was in NYHA class 4 breathlessness, treated, and in heart failure, with pulmonary hypertension in sinus rhythm with no active signs of rheumatic activity or infective endocarditis. I had one doubt, sir. When you say pulmonary hypertension, should we mention both venous and arterial hypertension, or should we just say
no, just mention pulmonary hypertension.
That's enough.
Okay.
How do you know the patient is in sinus rhythm?
So the
What is
You
sinus
just
rhythm?
mentioned regular rhythm. You can
Regular
mention
rhythm.
rhythm is regular.
sinus
Oh.
can't be commented. It has to be on ECG.
So you can say patient is not in
Regu-
atrial fibrillation.
Not in AF. Okay,
You are worried whether the patient is in atrial fibrillation
AF.
or not, isn't
Yes,
it?
sir.
So you can say patient is not in atrial fibrillation. That would be
Okay.
okay.
Okay, sir.
Okay. No signs of active rheumatic activity and infective endocarditis. Preferably, if you're writing, then you can write it in those 8 points. All the 8 points
Okay.
are there here.
Yes.
But preferably, if you're writing, you can
Stepwise.
write it one below the other. One below the
Okay,
other. NYHA will come the last. Functional
Last.
class is coming at the last.
Last. Okay, sir.
What is mitral annular calcification?
I don't know the definition, sir, but there is the mitral annulus gets calcified, so the patient may have like a functional MS. Like
No, what is more common, MS or MR?
in MS is more common, sir.
MR is more common.
MR. Annulus, na?
Yes, sir. But like, if it's
So
calcified,
MR,
will it dilate, sir? Or like I didn't understand how, sir.
no, the leaflet motion is impaired. Basically, the leaflet motion is impaired when the annulus is calcified, and MR
Okay,
MR
sir.
is more common.
Okay, sir.
So here, acquired valvular heart disease means one more possibilities. If we think here, maybe some bicuspid aortic valve presenting with early AR, but you didn't mention any click, right? You didn't
Click,
have any
no,
click.
no click. I didn't mention it, sir, but there was no click.
Yeah, if there is associated mitral annular calcification like that, it can occur. But isolated degenerative calcific aortic disease will not occur at 53 years. It will occur usually more than 65 like that.
65 years.
So other causes of multivalvular AR, MR means Marfan you can consider, but no Marfanoid features and all. Rheumatic may be the cause which is most common. Okay.
Yes, sir. I have an investigation. One is ECG, X-ray, and echo, sir.
Yeah.
So this is the electrocardiogram. So this shows a normal, well standardized ECG, 25 millimeter per second and 10 millimeter per millivolt, showing a normal sinus rhythm with a heart rate of about 150, about 100 beats per minute, with a prolonged PR interval. This is the P wave. So coming to sinus, because it's positive, P wave is positive and lead to AVF, and it's biphasic in V1 and negative in AVR. So it's a sinus rhythm, normal heart rate being 100 beats per minute. PR interval is prolonged. Sir, then rate rhythm interval. So coming to the axis, we have one positive, AVF is also positive. So it's a normal axis. There's no biphasic component here, so I'm taking it as a normal axis. Coming to the chamber enlargements, coming to the atrial enlargement, so there is a prominent left atrium enlargement here, sir. So the
By ECG, what are the indices you use to comment on left atrial enlargement?
One of the Morris index, where we take the terminal P wave terminal force. If it is more than 40 millisecond, then we consider the
any other index.
P by PR macros index if it is more than 0.16.
More than 0.1,
huh? Sir, yeah.
P by PR more than 0.1 or?
P by PR more than. More than one, sir.
More than 1 point. It's not
1.6. Oh, more than 1
point. It's not point.
1 point.
1 point. Yes. So these are the indexes that you have to
indices that we use. Apart from that, we have here the criteria for LVH.
If you had this patient had atrial fibrillation, can you make out whether there is left atrial enlargement? How? This patient has sinus. If atrial fibrillation was there, can you say whether there is left atrial enlargement? Coarse atrial fibrillation. You see the fibrillary waves, and the fibrillary waves are coarse, not fine. That would be also sine qua non of LAE.
Okay.
There is LAE, but there is no mitral valve disease. What is your inference? Not in this patient.
Secondary, we have to look for like LVH, secondary LV diastolic dysfunction.
Diastolic dysfunction.
QRS. Coming to the QRS, sir, there is a S wave in V1 plus R in V5, V6 is more than 35, suggestive of a left ventricular hypertrophy. There is a T wave inversion, symmetric T wave inversions associated with it, and some Q waves prominent in V5, V6. But
no, don't tell us symmetric T inversions. There is a
asymmetric T wave inversion.
Asymmetric.
There is a
Asymmetric
depression with the T inversion, as it's asymmetric, more likely suggestive of secondary to LV hypertrophy.
LV hypertrophy. Yes,
if the ST segment is flat and T wave is inverted, and if it's symmetric, it means suggests more of
ischemia. Yes, sir.
What is it? Volume overload or pressure overload of LV?
This looks like a pressure overload whenever you have a strain pattern.
Means you have that small Q waves in V5, V6.
But that indicates a volume overload. So
but then if it was isolated volume overload, you would have had upright T waves.
Yes,
upright. Here you have T wave inversions which are suggestive of a pressure overload also. Yeah.
So based on this prolonged PR, anything you comment why there should be a prolonged PR here? What all you can infer with that prolonged PR in this patient?
Can there be some degeneration of the AV node, sir? One possibility. Another is severe dilatation. LA, can there be an intraatrial block? Is one more thing I want to tell.
Now, see, you are telling rheumatic. Now, even rheumatic activity.
Acute rheumatic fever can cause a prolonged PR interval. One of the minor criteria.
Active rheumatic activity can cause, and one more thing is the aortic valve calcification. Severe aortic calcification can cause.
It can affect the
adjacent AV node, and it can cause all this prolonged PR.
Patient is on beta blockers.
Yes, sir. Patient is on beta blocker. He started on beta blocker. That can also cause.
Yeah.
How do we anything to comment on this notching, sir? Like many times we see like this notching that is there in like many leads. Like
what do you call
that is intraventricular conduction delay.
IVCD, yeah.
IVC. But any significance, sir, for that? Like fragmented QRS and all that. When we consider that fragmented, when to like differentiate that, sir?
No, if the QRS, if you see the QRS duration is less than 100 milliseconds only here.
Yes, sir.
It should not cause any problem. The QRS duration is significantly prolonged with associated notching, means again risk of arrhythmias and other things are high.
Okay.
Okay, next.
And the chest radiograph, sir. This is a chest X-ray of the PA view, showing the mediastinum and the lungs. So we say it is PA view because the.
It's okay. That part is okay. You can tell about the findings.
Findings, sir. So on first inspection, we have a gross cardiomegaly. There is no rotation and the exposure is adequate. Then we have the cardiomegaly that is seen. The LV type of apex, very obtuse angulation between the cardiophrenic. So there's a LV apex. Apart from that, there is a pulmonary increase in the prominence in the upper lobe vessel, so suggestive of a pulmonary embolization, early heart failure. And then whenever we have that, we look for the curly lines. Not clear here, sir. There were curly B lines actually in this patient.
Can you describe all that borders from left side and right side?
Okay, sir. So here on the left side, we have the aortic arch. Then we have the.
Tell us aortic knuckle.
Aortic knuckle. Aortic knuckle.
Arch. Okay.
Aortic knuckle. Then we have the pulmonary bay.
Yes.
Then we have the left atrial appendage.
Left atrial appendage is lower. That entire thing is pulmonary bay.
Entire thing is pulmonary bay. Entire thing is
left atrial appendage, and then there is the LV.
So left atrial appendage is pushed out. That's why you're not able to see that gap there.
Gap here.
Right side.
Right heart border.
Right heart border. It is going to correspond to the SVC. Sometimes the azygous veins may be here, sir. Along with that, this is going to be the RA. There is no RV is not represented in the chest radiograph.
No, one more thing. Something is missing there above RA.
Pulmonary.
What is that?
Main pulmonary trunk.
No. Sometimes ascending aorta forms a small border there.
Border
Okay.
there.
Okay, sir. This part, sir.
Yes.
Okay. Okay.
Is there a double density?
Yes, there is a double density here, sir.
Is
Like
this playing of Karina?
I'm not able to appreciate that.
I don't know. I can see it.
Not
Okay.
much. Not much.
But
Very
double
mild.
density is like still there, sir. Trachea is playing. Okay, sir.
Okay, so there is evidence of mitral valve disease. Left
Mitral
atrial
valve
enlargement is there.
Yes, sir.
The descending pulmonary artery is enlarged. Right descending pulmonary artery. Right descending pulmonary artery. Right.
Yes, sir. There is enlargement here, so there's a fullness here.
You have to measure it. The one which is there, branch which is there on the side.
Okay, sir. This one, sir.
That is the measurement. Usually in the longer, bigger X-rays, there is a measurement of that. More than that would indicate arterial hypertension.
Okay, sir.
Small digital ones, we don't have a corresponding measurement.
Okay, sir.
Okay, so it says that there is evidence of cardiomegaly, left ventricle is there, left atrium is also there, and pulmonary hypertension is also there.
Hypertension.
So all your features, what you said, were there.
Yes, sir.
Yes.
This was the sir. Showed a inherited LA, RB, concentric LVH with LV dysfunction of 40% EF, global hypokinesia of LV, thickened mitral leaf, severe MR, mild AS, severe AR, moderate to severe TR, mild IVC, TAPSE was normal, mild PR, and this patient underwent a double valve replacement, both the mitral and the aortic. He underwent a valve replacement for it, sir. Now he's doing fine. It just come for follow-up.
What are the class 1 indications for MVR?
Class 1 indications. Severe symptomatic MR.
Okay.
Answer. Second is class 1.
Okay, in asymptomatic, when you want to do?
When
asymptomatic MR, when you want to do surgery?
we look at the LVEF, sir. If there is LV dysfunction, then we think of operating.
Yeah,
less
how much LV dysfunction?
Sir, less than 40%, sir. Yes.
No.
I don't exactly remember.
See, suppose LV function is 25%. What you will do?
We stabilize and then take up for the surgery, sir.
No, what indication it is? Class 1 or 2A or 2B?
I'm not sure, sir. I'll read it up, sir.
See, LV function more than 30% is class 1 indication. Okay. Asymptomatic MR LV function between 30 to 60%, still a class 1 indication.
Okay, sir.
Okay, actually here in your record report you didn't mention dimensions, but if LV end systolic dimension is more than 40, that is also class 1 indication. Okay, but once if the LV ejection fraction drops to less than 30%, then it becomes class 2B indication.
B.
Okay, because once if the LV ejection fraction drops, means it indicates that it's a very severe stage. The patient may not benefit. He may not come out of bypass also.
Okay, sir.
You have to know the classes. Okay, class for all the valvular heart disease. You have to know the indications. That's asked.
Okay, I'll read it.
Yeah, Kartik, you were saying something.
No, nothing, sir. Just I'm asking about AR. What about AR?
AR indications.
Sir, if there is if the root dilatation more than 7 centimeter.
No. I'm not asking about root.
Root.
If you go to root again, no different questions will come. What is?
Okay. AR indication.
Okay, fine. AR is there. Root is enlarged. What you will do? What surgery you will do?
We'll do for both, sir.
Both means what is that surgery called?
What is the surgery called as?
Modified Bental, sir.
No, what is modified Bental? What is difference between Bental and modified Bental?
I don't remember, sir. Like I read it long. I don't remember
At what dimension you want to replace the aortic root?
More than 55, sir.
More than 5.5 centimeters, it becomes an indication.
Yes,
and for bicuspid aortic valves, it is even less. It's around 4.5, I think, for
45,
bicuspid
yes,
aortic valves. And for Marfans, it is even more less. I think for even 3.5 to 4 also, you should replace in Marfans.
Oh, no, Marfans it's 4.5 only, sir. 4.5 for Marfans.
4.5, oh, Kishan?
Yes, sir. Yes, sir. Marfans
Okay.
4.5. We recently
Bicuspid
did
aortic valve, it's 5, right?
also 4.5, sir.
4.5.
Yes, sir.
Okay.
Yes, sir. And any connective tissue disorders in this thing, family also 4.5. Then there are two guidelines, sir. One European and one US. That's some 0.5 difference is there between two.
Okay. Then what are the class 1 indications for aortic valve replacement?
Class 1 indication is whenever it is like AS, if there is a severe symptomatic AS.
AR.
Severe AR is an indication, sir. And any moderate, even if it's moderate and presence of an LV dysfunction.
No, patient is suppose having no symptoms, then severe AR. Still you want to do?
The first indication is always.
See, the easy way I'll tell you. Okay, see, whenever someone asks class 1 indication, you tell first as symptomatic severe AR.
Symptomatic
Yes,
yeah, that you should word symptomatic severe AR. And if it's asymptomatic, when you should do is if the LV ejection fraction is less than 50%.
Less than 50%.
Less than 50%.
Yeah, that is a class 1 indication. Again, if you want to see the dimensions and all means, again, if LV and systolic dimension more than 50, then it becomes a 2A indication. Or suppose a patient is having severe AR with severe MR, some other cardiac surgery you are planning, then again you can go for aortic regurgitation. So this patient before surgery, did you do coronary angiogram?
Yes, sir. They done coronary angiogram. It was normal, sir.
Normal coronaries.
Normal coronaries.
Okay. So suppose if a patient is having some right coronary artery 50% lesion, what you will do?
Sir, this is intermediate stenosis where we have to look for the fractional flow reserve. If it is less than 0.8, it becomes significant. It's a hemodynamically significant lesion. Then we might have to stent it, otherwise not required.
Stent it?
Like we have to, if there's more than 50% occlusion, then we advise the antiplatelets, statins.
No, patient is having 80% RCS stenosis. Now tell what you will do.
CABG.
Yeah, you will do CABG. You will do a graft. You will give a graft to PDA during
the surgery. Simultaneously, while doing the replacement, we go for a CABG.
Yeah.
If it's like only isolated, like only 50%, then like we think of that FFR and then think of it.
FFR again in this patient it will have very
not
much
here, sir. Like since like you had asked that 50% like intermediate stenosis. Then
no, because you told I'm asking how the FFR affects in this patient. Here all this LV and diastolic pressures and all.
Because of that, it will be affected. It will be very high. Sir.
Yeah.
Naturally, it will be more than 0.8. It will be less. It will be significant, sir.
FFR will be falsely. FFR may be false. It means even the significant lesion may not be because the distal pressure is also increased here.
Increased here, yes, sir.
And Kishan, when you are doing this graft with AVR, which one you will do first? First you will replace the valve and then you will put a graft, or?
No, nowadays we get this composite the grafts, sir. First we'll put the graft. We'll take the sutures bites for the graft in the annulus, and then we put the elbow graft. Then we finish off the valve part, sir.
It means first you will do CA bypass and then you will go for valve replacement.
Yes, sir. Yes, sir. Yes, sir.
Okay. And in the DVR and MVR, both are done, na? Which valve you will replace first?
DVR first mitral valve, sir. First mitral valve, then we go for aortic valve.
Yeah, because if you put aortic valve first, there may not be space for the mitral
Yes,
valve.
sir.
Right?
One, yeah. Supraannular, yeah, yes.
Yeah, first always replace mitral valve and then go for the aortic valve.
Aortic valve.
These cases, na, if one more thing during exam, suppose if patients examiner asks regarding heart failure management, always try to tell in an order, like instead of directly going for IV diuretics, tell all this like fluid restriction to less than 1.5 liters, low salt diet, propped up position. These all common things you tell like fastly only, like low salt diet, fluid restriction to less than 1.2 liters if heart failure, propped up position, O2 inhalation or CPAP inhalation, SOS. Then you go with the diuretic and AC inhibitor. And in this patient, you want to give beta blocker?
Acute heart failure, beta blockers and calcium channel blockers are not recommended, sir.
Okay. Other than that, suppose if severe AR is there, do you want to give beta blocker in severe AR?
If we give severe beta blocker, heart rate reduces. AR will worsen if we give a beta blocker.
Yeah, AR may worsen. That's why even AR patients, sometimes they keep on walking to keep the, they'll feel less, because whenever there is bradycardia, the AR is increased.
AR is worsened, yes, sir.
Severe AR and
actually,
hemodynamic also. And severe regurgitant lesions don't prefer beta blocker, because the cardiac output is maintained on heart rate only.
Heart rate, yes.
So that's what these all you should read. When to introduce beta blocker, when to introduce AC inhibitor.
AC inhibitors.
All this. And read about ARNI also. All the examiners.
ARNI, yes. The trials, paradigm HF trials.
What is the ARNI composition?
Sir, one is angiotensin receptor and neprilysin inhibitor. So valsartan, sacubitril and valsartan.
Yeah, sacubitril with valsartan. Sacubitril 24 mg and valsartan 26 mg. In 50 mg tablet.
Yes,
in 100 mg means it will be difficult.
49,
51.
51, yes.
And now ARNI came class 1 indication. No? ARNI is a class 1 indication.
All, like they say that sledgehammer approach where you start all of the four simultaneously. Like me, beta blocker, MRA and SGLT2.
Yeah.
ECMO is that recent talk.
Yeah. Okay. Nice presentation.
Any other questions are there? No, I think.
I have answered many questions, sir, in the chat.
Yeah, that is.
Concluding remarks by both Archit sir and Kartik sir, please. For a second year MD general surgery, general medicine resident, how good or how bad the presentation was, and how can we improve? Please, concluding remarks about the presentation and also about the diagnosis.
His presentation is good. Good presentation. And regarding this, at these areas and all, as we go advance, we usually won't tell by areas. We'll tell first sounds, then followed by murmurs directly, depending on significance of murmur. See, you described first mitral area, but the mitral and later tricuspid area. Tricuspid area need not be much significant. So we go by more of with the significance of lesion in that way. Otherwise, it was good.
Yeah, the case presentation was good. Yeah, the case presentation was good. Just picked up all the findings.
He answered all the questions.
Yeah, he answered almost all the questions was answered. So presentation has been very good. The pattern, I think, whatever, it's a traditional way of writing. Most of the examiners would want that pattern possibly. Yes, but clinically it might be different. But this pattern has to be followed for the exams. That's needed.
Sir, the question was, is it required to know this surgery, sir? Like for mitral valve, for the aortic valve? Like just being now Bental, so like modified Bental as we involve the aortic.
Balaji, no need to know in detail, okay? But like just Kartik sir was mentioning now, know the names at least, and what been
What
done.
they do
Okay,
it.
no need to know the details of surgeries or particulars and all. Okay, some
Okay.
like indications and all theoretical part at least you should know.
Indications
Like
you have to
it
know.
was an
Indication
apt
is
question.
yeah.
What are the
Very
indications
question.
for?
First one.
Okay,
Class
And
what are
know
the
about
indications?
you have to know
just
for
know
all.
about valves also, like at least Chitra valve, you know, because one that is being used in India everywhere.
Yeah.
Just know that Chitra valve is a single leaflet valve and a metallic valve.
Metallic.
They may ask what are the types of valves. It's a metallic valve, bioprosthetic valve.
Bioprosthetic valve.
Metallic valves can be single leaflet, bileaflet. St. Jude is bileaflet, Chitra valve is single leaflet, and bioprosthetic valves.
Right.
Like very some theory you know regarding that. And one more thing, anticoagulation also you should know.
You have to know.
Very much they can ask you about this.
Yeah, that you should know. Limits you should know. So at least indications and that part you should know. Okay. Otherwise, very well presentation, Balaji.
Regarding the
Really-
aortic valve, just remember about tower and TAVI also. A lot of questions are asked both in TV, your theory as well as lot is asked in practicals. So read
Okay,
about it.
Tower.
What are the
Okay.
indications and what are the
recent advances. Yeah.
It has to be read.
Wonderful presentation as usual, Balaji. I think this cannot be better than any resident presentation cannot be better than this. Okay, almost answered everything, and examiners are also like mentors are also happy. We also learned a lot of things from your presentation. Thank you so much for helping us to learn better and better. And special thanks and special regards to both of our eminent mentors today, Archit Boloor sir and our own Viswanath Kartik sir. Thank you so much. Keep guiding us, keep blessing us, and keep teaching us like this. And thank you for all our viewers for being constant support for us. Thank you so much.
Yeah.
Thank you.
Thank you, sir.
Thank you.
so
Thank you. Bye. All the best.
much. Thank you.